Hi everyone, thanks for joining me today. My name is Sara Lingow. I'm a PGY2 ambulatory care pharmacy resident here at St. Louis College of Pharmacy and the St. Louis County Department of Public Health. I wanted to thank the Alumni Association, the Still Cup Alumni Association, for inviting me to present to you guys today this brief overview on updates in immunizations, the CDC recommendations for the 2017 and 2018 vaccination year. If you guys have questions throughout the presentation, feel free to use the comment function on the presentation to ask me questions. I won't address any questions until the end, but I'll be happy to either answer your question or help you find a resource to answer your questions. So thanks again for joining me, and we'll go ahead and get started. Sorry. All right, so the outline for today's presentation. First, we're going to talk about the influenza vaccine for this year. Then we'll just very briefly talk about the HPV vaccine and new recommendations surrounding that. And then we'll talk a little bit more in detail about the new herpes zoster vaccine. Some of you may have heard some buzzing about the new vaccine, so we'll talk in detail about that. And we'll very briefly review co-administration. Sometimes there can be some confusion about when we can give vaccines together and when we can't, so we'll kind of review what the CDC has to say about that. And then at the end, I provided some resources for you all as far as where you can find the information that I have provided for you today and more information that we didn't go over today. So starting with the 2017 through 2018 influenza vaccination recommendations. So just as a background about the influenza vaccine in general and how it's developed, so there are two main strains of influenza that we're worried about, influenza A and influenza B. Influenza A can cause moderate to severe disease, and the subtypes that are sort of determine this disease are hematogluten and neuraminidase. So when you think H1N1 or H3N2, those are going to be influenza A subtype vaccines or strains. Excuse me. And then influenza B, this is going to be a more mild disease that usually occurs in children. As far as how the viruses are named, the first part of the name is the virus subtype. The second is the geographic origin where it was first isolated. The third is the strain number. The fourth is the year of isolation. And then the fifth is the virus subtype, just to sort of orient you to what you're looking at when you're looking at the strain of a virus. And then as far as antigenic shift and antigenic drift, so this is really the reason why it's required to get a new vaccination or a new influenza vaccine every year. So antigenic drift describes a major change or a new subtype in a vaccine, and it's caused by a point mutation. And this may result in an epidemic. So this is why we need to continually have new vaccine strains every year to sort of account for the antigenic drift. Antigenic shift is a little bit more worrisome. So this is actually caused by an exchange of gene segments, and it may result in pandemics. So the H1N1 vaccine, or the H1N1 virus of 2009 caused a pandemic. And so this is why it's so important for us to have new vaccines every year, and something that you can tell your patients, there's a new viruses develop every year because of these things, and so that's why it's important to get a flu shot every year. As far as the burden of influenza illness, just again as a reminder, I know you all are familiar, but kind of could be convincing points for your patient to encourage them to get the flu vaccine. Annual epidemics usually occur between October and April, so the goal would be to get patients vaccinated before this time frame. Most outpatient influenza visits occurred in children, and so that's why it's important to encourage not only parents and adults to get their vaccines, but also encourage them to have their children vaccinated as well. Hospitalizations and death related to influenza occur in patients age greater than or equal to 65, so our elderly patients and children. So these are really the target age groups. I mean, we want to target everybody. CDC recommends influenza vaccine for all patients age greater than or equal to 6 months, but these are the two groups of patients where influenza can be very concerning and lead to hospitalization or death. So we certainly want to target those patients. For the 2015-2016 influenza year, there was an estimated of 25 million influenza illnesses, 11 million influenza-related medical visits, 310,000 influenza-related hospitalizations, and 12,000 pneumonia and influenza co-infection-related deaths. So it's definitely something that is a burden, not only in 2015 and 16, but every year there are influenza-related hospitalizations and deaths, and so significant impact on patients' health, especially between that October and April timeframe. So there's two different types of influenza vaccine that we're specifically recommending this year. There's inactivated and there's recombinant. So inactivated is what you're mostly going to be seeing and mostly giving to your patients. But the recombinant influenza vaccine is mostly recommended for patients with an egg allergy. However, in most pharmacies, they're going to have the inactivated influenza vaccines in stock. So there's a trivalent and quadrivalent. The trivalent contains 2 of the A strains and 1 B strain. So like I mentioned, the A strains are going to be the vaccine strain, or be the flu strains that cause the most significant disease, more severe disease, and then the B strain is going to cause more mild disease. And so that's why it's important to make sure we cover for more A strains than B. However, the quadrivalent vaccine has all 3 strains that are included in the trivalent vaccine, but also included an additional B strain. So there's 2A and 2B in the quadrivalent vaccine. As far as vaccine supply, so manufacturers estimated that they would produce between 151 and 166 million vaccines for this flu season. So that certainly should cover all of your patients. So we shouldn't really be worried about a shortage of influenza vaccines this season. This chart looks a little busy, but I just wanted to make you all aware of how many different influenza vaccines there are available currently. Some that may look really familiar to you are perhaps the Fluzone, Fluarix. Those are commonly carried in pharmacies. Maybe the intradermal vaccine. You can see that that one here is obviously intradermal vaccination or intradermal administration. And then Flublok, those are going to be your recombinant, compared to the inactivated. These are going to be your recombinant strains. And of course, the high-dose vaccine is the Fluzone trivalent. So just talking a little bit more about high-dose and what that means. High-dose flu vaccine is recommended for all adults age greater than or equal to 65. This is, like I mentioned, the trivalent high-dose inactivated influenza vaccine, and it contains 4 times the amount of antigen as the regular flu vaccine. So why is this important? Well, it was found that the high-dose vaccine was about 25% more effective in adults age greater than or equal to 65. So it has been shown to have better efficacy in preventing the flu in this age group, and so that's why it's recommended for all patients age greater than or equal to 65. And then just speaking very briefly about the live attenuated influenza vaccine. This is a quadrivalent vaccine. It's called FluMist, but it's not recommended this year, and that's because it didn't really show efficacy against the flu strain during the 2013-14 or 2015-16 flu seasons, and so we are not going to be recommending. The CDC doesn't recommend that this year, so we're not going to be recommending that to our patients this year. So just, again, as a quick overview, quick reminder, who gets the flu vaccine? All patients age greater than or equal to 6 months. What is it, or what should they get? They should either get the inactivated trivalent or quadrivalent strains. CDC doesn't recommend trivalent versus quadrivalent, just knowing that the quadrivalent vaccine is going to provide that extra strain against that B virus, but CDC doesn't necessarily have a preference on which vaccine patients get. When is the optimal administration? By the end of October. So hopefully most patients already have their influenza vaccine. However, efforts should still continue throughout the flu season. Even through February, patients should be vaccinated if they have not had the influenza virus already. And then even vaccine administration through December is likely to be beneficial after the influenza season has begun. So it's still going to kind of help prevent that disease in patients even during the flu season. Again, a lot of patients are resistant to getting the flu vaccine. They say that it doesn't work, or as soon as they got the flu, or they never get the flu, so they don't need it. So just kind of honing in these talking points with them. Influenza vaccine was found to reduce deaths in children, so that's why it's so important to encourage parents to vaccinate their children with the flu vaccine. Influenza vaccine may make the illness milder, so a lot of patients say, well, it was only shown to be 30 to 40% effective 1 year. Well, even if they were to get an influenza vaccine after already receiving, even if they were to get the virus after receiving the vaccine, that virus and that infection and illness would be milder if they did have the vaccine. And then furthermore, data from the 2017 flu season showed that influenza vaccine reduced mortality, reduced ICU admissions, and reduced hospital length of stay. So all beneficial reasons to get the flu vaccine. And of course, we all know that it can't cause the flu because it's inactivated. It can't cause the flu. And if patients are having symptoms of the flu, it could have been that they were already infected. It does take 2 weeks to have full antibody prevention or protection against the flu. So could be that the patients were already infected, could be they have something else like a cold that has similar symptoms to the flu, but patients can rest assured that the flu vaccine does not cause the flu. So just very briefly talking about the human papillomavirus or the HPV vaccine, just some updates on that. Some of you may not be regularly administering this vaccine in the pharmacy, but just in case you do get questions about it, I think it's important to know the updates. So there's really 3 different vaccines that we think about when we think about HPV. We think about Gardasil, which is 4 strains of the HPV vaccine. We think about Gardasil 9, which is 9 strains. And then we have Cervarix, which is actually only 2 strains. Both Gardasil vaccinations can be given to male and female patients, but the Cervarix is really only recommended for female patients. And then the age, that it can be administered is a little bit wider for Gardasil, 9 to 26 compared to 10 to 25 with Cervarix. Both Gardasil vaccinations are 3 doses administered at 0, 1 to 2, and 6 months. However, the update that I wanted to make you guys aware of is that new studies showed that the Gardasil 9 can be administered in 2 doses instead of 1. So it can be administered at 0 and then 6 to 12 months in male or female patients who have not previously received the vaccine, ages 9 to 14. So in this specific age group, the Gardasil 9 can now, it's approved to only be administered in 2 doses rather than 1. Just as a reminder of who should be getting the Gardasil vaccine, it's pretty much all patients within this age group. The routine age recommended is age 11 to 12 for both males and females. That's kind of when we should start talking to parents and patients about getting the vaccine. But of course, like it says, it can be started as young as age 9. All immunocompromised males, including HIV-infected and MSM patients through age 26 should still be vaccinated. And so basically the update is that the 2-dose vaccine for Gardasil 9 is what's recommended in this specific age group. So that's sort of new this year, and I just wanted to make you all aware of that. But if you have any questions, more specific questions about HPV vaccine, feel free to ask. Lastly, I wanted to talk about the new herpes zoster vaccine, which I'm sure you all have at least heard a little bit about, the new Shingrix vaccine. So we'll just kind of get right into it, comparing and contrasting the Shingrix versus Zostavax. So really, what's the difference or what's the similarities between the two? So Shingrix was just approved by the FDA in October 2015, and then later at the end of October approved by the Advisory Committee for Vaccinations panel, and we'll talk about their recommendations in a little bit. But it's brand new. It's manufactured by GlaxoSmithKline. Zostavax was approved in 2006, so it's been around for over 10 years, and it's manufactured by Merck. Shingrix is an inactivated vaccine, so it's a recombinant adjuvanted vaccine. However, the Zostavax, as we know, is a live herpes zoster vaccine. Shingrix is going to be intramuscular administration, whereas Zostavax is sub-Q. Shingrix is 2 doses, so 1 dose and then another dose 2 to 6 months later. And then the Zostavax is only 1 dose. Shingrix is approved for all patients age greater than or equal to 50 years, whereas Zostavax is approved by the CDC for patients age greater than or equal to 60, but the manufacturer actually approves administration between the ages of 50 and 60, so patients are required to have a prescription during those 10 years. The availability of Shingrix is expected to be later in 2017. I couldn't find an exact date of release, but it's supposed to be within the fourth quarter. So I would anticipate that it's going to be coming out pretty soon because it was just recently approved. Of course, Zostavax, because it's been around for a while, is currently available. And I just included the estimated cost between the two. So the cost of the 2 doses of Shingrix together is anticipated cash price to be $280, and then the cost of Zostavax is anticipated to be about $223. So a little bit more expensive for the Shingrix for the 2 doses, but it's certainly going to be worth it, and I'll talk about why in just a second. So just looking at the clinical trials that led to the approval of these vaccines, we'll start with the Zostavax. There was a study put forth in the New England Journal of Medicine by Oxman and colleagues, the Shingles Prevention Study Group in 2005, and it showed about 60% efficacy against herpes zoster in age 60 to 69 and about 55% efficacy in that older age group greater than or equal to 70. Efficacy against postherpetic neuralgia, so patients who were already infected with shingles or herpes zoster, efficacy was shown to decrease about 66 to 67% in both age groups. So significant efficacy against postherpetic neuralgia, but as far as against herpes zoster, it's not incredibly impressive. But now we look at these new trials that led to the approval of Shingrix, the new inactivated shingles vaccine. And the first one was called Zoe 50, published in the New England Journal of Medicine in 2015. And this showed incredible efficacy against in preventing herpes zoster. So in patients age 50 to 59, it showed 96.9% efficacy. In patients age 60 to 69, it showed 94% efficacy. And then in patients age greater than or equal to 70, there was 98% efficacy, but there was not a lot of patients in this age group represented in the study, and so that's what led them to do the Zoe 70 trial. And I just wanted to mention here that the efficacy in preventing herpes zoster was after receiving at least 1 dose of the vaccine. So most of the patients did get both doses, but these efficacy numbers include all patients who perhaps maybe only received 1 dose. So even with those patients who received 1 dose, there's still this high of efficacy. So that's really impressive, really great to see with this new vaccine. As far as efficacy against postherpetic neuralgia, there wasn't a large enough sample in the Zoe 50 trial to include or to have this as an outcome. But as you can see in the Zoe 70 trial, they did look at that. So Zoe 70 was published after Zoe 50. It included all patients age greater than or equal to 70, and it looked at the efficacy of the vaccine in those age groups. And so, as you can see, it was still highly efficacious in patients age 70 to 79 and patients age greater than or equal to 80. And then they pooled the data from Zoe 50 and Zoe 70 to look at efficacy against postherpetic neuralgia, and they found a decrease in about 88% in the age greater than or equal to 70 group. So also can be given to patients who have already had shingles to kind of decrease that postherpetic neuralgia. So as we can see, the efficacy of the Shingrix compared to the Zostavax is significant. As far as just some points about the vaccine, and it, once you get it in the pharmacy, things to know about it. It goes in the refrigerator, not the freezer, so it's stored refrigerated. Reconstitution with the adjuvant suspension provided by the manufacturer is recommended. And then as far as stability, the vaccine should, of course, be used immediately following reconstitution, but actually it can be stored in the refrigerator for up to 6 hours after reconstitution. So if for some reason you're not able to give it right away, it is good for up to 6 hours in the fridge after reconstitution. And then finally, just going over the ACIP recommendations. So they met on October 25th and 26th, and they kind of concluded with these recommendations after that meeting, after kind of reviewing the literature. They recommended that all immunocompetent adults greater than or equal to 50 get the vaccine. They recommended that for the prevention of herpes zoster and related complications, even patients who have received Zostavax should get Shingrix. So unfortunately, those patients who receive Zostavax should get the vaccine, but just kind of be counseled that this vaccine will provide even greater efficacy against herpes zoster. And then that Shingrix is preferred over Zostavax. So that's now going to be the one that we recommend for patients for the prevention of herpes zoster and related complications. And then lastly, I'm going to talk a little bit about co-administration. I know that sometimes this can be a tricky concept and sometimes not quite clear, but the CDC, I feel like, does a pretty good job of kind of clearing up this potential question or potential issue that people might have. So the general rule of thumb recommended by the CDC is that all vaccines can be administered at the same day, on the same day as all other vaccines. So the idea or the goal would be to try and vaccinate patients and get them vaccinated all at once. The spacing of the vaccine combinations should not, or there are some vaccines that should not be given simultaneously, and that really comes into play when we're giving 2 live vaccines. So any live vaccines should be separated by about 4 weeks. I think a common misconception is that live vaccines should not be given with inactivated vaccines, and that's not supported by the CDC. It is appropriate to give a live vaccine and an inactivated vaccine on the same day. I know that there can sometimes be a question about this, specifically thinking about Zostavax and the pneumonia vaccine. So there was a 2009 study that looked at efficacy of giving those 2 vaccines on the same day compared to separating them by 1 month. And the study concluded that there perhaps was lower efficacy of the Zostavax vaccine after giving it in conjunction with the pneumonia vaccine. And so some practices kind of separate those by 1 month. It's recommended by the manufacturer of the Zostavax vaccine. But that recommendation is not supported by the CDC, and so it's not necessarily a widely accepted practice, but it is something that you may run into. I know there are certain pharmacies that have that recommendation, and so just wanted to make you aware of the data behind that as well. And then finally, I have resources for you all. So I got almost all of my information for today's presentation from the CDC website, from ACIP, which is the governing body, of course, that makes the recommendations, and then the Pink Book, which is updated every year, and it has really great info about background about vaccines and then vaccination schedule, and it even has a section just for updates in the previous year. So it's really helpful, a really great source. And then I encourage you, if you ever give a vaccine, or if you're in a clinical setting where a vaccine is given and a patient does have an adverse event, I encourage you to report that at this website here. It's always just a good practice to report any adverse events of vaccines, especially with these new vaccines coming out like Shingrix. We want to make the manufacturer and the CDC aware of things like that. As far as those people who live in Missouri, there's a great website that you can look at as far as recommendations for immunizations on that Missouri website, health.mo.gov. But there's also a new immunization registry that I'm kind of excited about called Show Me Vax. So the Missouri Department of Health and Senior Services has put together an immunization registry that you as a practitioner can sign up for. You just have to go to that link and sign up, but you are potentially, depending on if your patient is registered, you're potentially able to see their vaccine history, which can be a really great way for us as pharmacists to catch our patients and kind of identify which vaccines they have, which vaccines they need, and kind of help them get all of their vaccines that they are indicated for. And then for those folks who live in Illinois, there's that link for Illinois immunization recommendations as well, in the Department of Public Health for Illinois. So with that, I certainly encourage any questions that you may have. Again, my name is Sara Lingow. I am a graduate of the college. I don't know if I mentioned that before. I graduated in 2016, and I'm really happy to have talked to you all just really briefly about the updates in immunizations, and I would love for you to ask questions, so you can either chat me here or email me. And thanks again to Stephanie and the Alumni Association for allowing me to participate in this webinar series today. And if you have friends who are not able to view the webinar, this will be available for them on the SOCOP alumni website in about a week, I believe. And, or, you know, if you just want to review the updates yourself, you can certainly review this presentation and other presentations that other alumni have put together there.